I'm Rita Basu. I'm a professor of medicine at the University of Virginia in Charlottesville in the Division of Endocrinology, Department of Medicine. I also am vice chair of the Institutional Review Board there. And both my husband, Ananda Basu, and I just moved recently from the Mayo Clinic, where we did our work and research for over 25 years.
So, and I am Ananda Basu. I'm the better half. As Rita mentioned, I'm just kidding. As Rita mentioned, our research career started at Mayo Clinic back in 1993. We have, our research is mostly on the physiology of both type 1 and type 2 diabetes and pre-diabetes, so that to understand what goes wrong in these people with diabetes, both type 1 and type 2 diabetes. So we recently moved to the University of Virginia in Charlottesville, in Virginia, where I am the director of the Diabetes Technology Clinic at the University of Virginia. And I do research primarily on type 1 diabetes and providing physiological inputs to the state-of-the-art artificial pancreas for people with type 1 diabetes. So these are the basic introductions. So with this, I think I would ask Rita, to try and explain some of her recent work on nighttime glucose control in patients with type 2 diabetes. Because as you know, most of the research in type 2 diabetes and the medical management of type 2 diabetes has been to control blood sugars during the day. Now, the nighttime, which is about 8 to 10 hours, is a substantial portion of the 24-hour period. And we have had very little knowledge about what happens at night in patients with type 2 diabetes. So Rita, for the last 4 to 5 years, has done a lot of work on glucose control and what goes wrong in people with type 2 diabetes when they're asleep, because that's 1/3 of the day, and we cannot ignore that. So over to you.
Yeah, so that's a great question. So as Ananda pointed out, that the focus of clinicians is when patients come to the clinic in the morning and they want to know how to manage their blood sugars, so based on their morning fasting glucoses, because most of the patients come to the clinic in the morning. Now, what we as clinicians need to remember is what happens in the morning is determined by what happens the night before. So the blood sugars in the morning are not going to, if the blood sugars are, say, 300 in the morning, then it's important for us to know when did those blood sugars start getting that high. Was it at 10 o'clock at night? Was it at 1 o'clock in the morning, 4 o'clock, or 7 o'clock? So what I went about doing as part of my NIH-funded grant in the US is that I brought in patients who had type 2 diabetes and also those who did not have diabetes, and I monitored them all night. We did this with various interventional measures. Of course, it is a very invasive, intensive study, but we had to do this overnight in the clinical research trials unit, and we did serial blood samples to look at blood sugars and hormone levels to see what could be driving this. And what I have found so far, and this is what I presented and writing it up for a publication, is that the nighttime sugars are determined by what happens at 10 o'clock at night. So if at 10 o'clock, 11 o'clock at night, the blood sugars are 300, they're likely to stay 300 at 7 in the morning. So there's no magic increase or decrease overnight. It's pretty much flat all night. And that's very important for the doctors because we need to target the nighttime sugars better. So if we want better morning glucose control, then the nighttime sugars need to be controlled better. So that is one of the things I looked at. And I also looked at which hormones play a role in this. So there's various hormones, as we know, interplay of insulin, glucagon, cortisol, et cetera, which all have a role in how blood sugars are managed in patients with diabetes. So as part of this NIH grant, I'm looking to tease out whether is it important for glucagon. Do we need to find measures to lower glucagon levels at night, which tend to increase remain high all night in patients with diabetes, or is it cortisol levels? So these are some of the things I'm looking at. And of course, the next follow-up to this would be I'm going to look at what happens all day. So my husband did studies in type 1 diabetes many years ago where he looked at diurnal pattern of insulin action. Do you want to tell them a little bit about that?
So basically the way insulin works is it lowers blood sugar, especially after a meal. Because when you and I eat, if you do not have diabetes and our pancreas, our cells are working normally, once we eat, our blood sugar start to go up, and then the pancreas secretes more insulin. Now, the insulin works by lowering blood sugar, and that is by mainly two different mechanisms. One is that it prevents the liver from making excess sugar, and the second is that it pushes the blood sugar into the muscle cells, which utilize sugar as energy. Now, the efficiency of insulin, does it change during the day? Is it constant in the morning as well as at lunchtime or in the evening? And that is important because we need to know when we're treating patients with diabetes, whether we need to give the same amount of insulin in the morning versus the afternoon or in the evening. So in some of the earlier studies that I did a few years ago at Mayo Clinic, we looked at this diurnal or the circadian pattern of insulin action or insulin efficiency. Does it differ between breakfast, lunch, and dinner? And we found that in non-diabetic people, in healthy people who have normal pancreases, insulin works best in the morning at breakfast. So the insulin efficiency is best in the morning, while as the day progresses, insulin effect becomes less and less. Now, we do not know why that is. That is something that needs to be looked at. But these are in healthy people. In patients with type 1 diabetes, it's just the opposite. That in patients with type 1 diabetes, insulin is least efficient in the morning and more efficient as the day progresses. Again, why is that? Whether it's some other hormones interfering or modulating this, we do not know yet. But this information is important when we're building this artificial pancreas. Because what is an artificial pancreas? It's basically an electronic pancreas. We are using artificial intelligence and algorithms within the insulin pump, like an electronic brain, so that we can inform this electronic brain that in patients with diabetes, insulin works the least efficiently in the morning versus at lunchtime and in the evening time. Hence, for the same meal, the pancreas, the artificial pancreas, needs to give more insulin in the breakfast than at lunch and dinner. Although the engineers and the mathematicians are building the brain, we as physicians and as physiologists need to tell the mathematicians how to program that brain. And that is where we as doctors and physiologists needs to inform these mathematicians that is how they need to program the brain. So similarly, what happens when these patients exercises? Okay, when the patients exercise, their muscles are moving more, they need to utilize more sugar, so the insulin action changes. Now, how much it changes by, these are the parameters that we need to measure during our physiology studies so that we can inform the mathematicians that is how they need to program the artificial pancreas, so that we can personalize or individualize the artificial pancreas to a patient. Because as we know, when we treat patients with diabetes in the clinic, no two patients with diabetes are the same. Each patient is different than the other. So we need to personalize these algorithms that are present in the artificial pancreas so that this artificial pancreas program will work for that patient and not for another patient. So the other patient, we need to program it differently. So that is why we as physicians need to inform the engineers how to program these artificial pancreas algorithms specific to that patient. That is where we come in. So now Rita has done a lot of work on glucose sensing, because if you look at the artificial pancreas, it not only delivers insulin, it delivers insulin based on the blood sugar levels, okay? So unless the algorithm or the brain or the program knows what the blood sugar is, they would not know how much insulin to give. So as you know, these blood sugar, the way that artificial pancreas measures blood sugar is through something called the continuous glucose monitor. like the Dexcom monitor, like the Abbott's flash glucose monitors, etc. So now these glucose monitors measures glucose in the fluid that is present in the cells between the fat cells of the abdomen, called the interstitial fluid. Now, Rita has done a lot of work on the glucose sensors to improve their safety and efficacy and the physiology of the glucose sensor. So maybe she can talk about that, about the time delay and drug interference of these.
So basically, many years ago when the artificial pancreas work was being initiated by various centers in the country, one of the drawbacks we found was exactly what Anand mentioned, was the continuous glucose monitoring devices, which were, remember, now we have much better devices, but several years ago, they were in the early stages of development. And the engineers, as he mentioned, were already starting to build these artificial pancreas algorithms, so that they were trying to determine if the blood sugar is this, then this is how much insulin needs to be given through that device or through that little machine. But it was important to know, is that blood sugar reading accurate? Otherwise, we would be underdosing or overdosing these patients. So that's where I started looking at this field, because I found that nobody had actually looked at the continuous glucose monitors in that way. That, we usually take blood samples from the veins in the patient, and so that is giving us real-time blood sugars. But this, as you mentioned, is the CGMs are placed in the subcutaneous tissue, so it's measuring what is called interstitial glucose. So is there a difference between, or a lag time between what is measured in the blood, in the plasma, and in the interstitial fluid? That was not known. So that's where I started my research. I wanted to see what's the time delay, because perhaps the blood sugar is 90, but the interstitial space is still reading something different. And because we are basing our artificial pancreas work on the interstitial fluid, we may be misrepresenting or misunderstanding what is the actual glucose value. So when we looked at that, we did find that there was a time shift. So the time lag with those devices that we used at that time, we used the devices later on, but through the microdialysis technique, which we put in pumps, we keep pumps in the interstitial to measure interstitial fluid, we found that there's like a time lag of about 5 minutes or so. And in healthy people. And in patients with diabetes, it was even longer. And these are all papers that we published. So we were able to tell the world that actually the reading that you're getting of the continuous glucose monitor may be like 6-7 minutes delayed, So that's very important for the artificial pancreas, because it is measuring real time. And so the way we will handle it is we have to factor that into the CGMs. So the CGM companies have to come up with a better way to fix that problem of the time delay. So that was one thing. Then we also found that, this is 4 or 5 years ago, the CGMs that were available also had a lot of interference with common medications. The commonest medication being acetaminophen or Tylenol. Okay, it's what we take for fevers. So, and it is present in all kinds of cold medicine, everything contains Tylenol. If you go to the drugstore and look in the counter and ask the pharmacist there, tell me what all contains Tylenol, he'll probably take out a whole box and give it to you. Okay, now here's what happens with Tylenol, with those older CGMs. And, we still haven't addressed it fully, we don't know yet. But what Tylenol does is it shifts the electrical voltage current in the CGM. And because of the shift in the voltage, it causes interference. So basically, when the blood sugar of the patient could be 90, it's reading 200. And that's just because of the voltage shift. And this was true for the Dexcom, et cetera, sensors that were being used several years ago. Now, with every new generation sensor that Dexcom is putting out, they think the interference is getting lesser and lesser. So they're trying to address it. But as far as I'm aware, at least up to the Dexcom 5 that we use, there's still interference. Right. It is less. The earlier ones were worse. And I have published all this to show what a huge difference it makes, because patients don't know, because they are sick or their children have fever and they're giving them Tylenol. Then they're measuring with the CGM and they're getting this high blood sugar value, which they think it's because they have hyperglycemia, and giving them more and more insulin. So this was a huge problem. So we recognized that this problem exists, and then the CGM company started working towards correcting this defect. What we have been told, we don't know yet, we have to test it out ourselves and see, is the new generation that's going to be launched soon in USA, the Gen 6, that probably is going to have no interference. But we need to test it out. So these are some of the issues we noticed with this CGM devices that are probably a little bit of a hold up for the artificial pancreas.
And even, 2 tablets of Tylenol, like 1 gram of Tylenol, can cause interference of the CGMs that we tested by up to 8 hours.
Yeah.
So just not a short-term problem. It's a longer-term issue. And there are other drugs that have been shown to interfere, drugs that are commonly taken consumed by diabetics, like ACE inhibitors, diuretics, even wine seems to interfere with some of the CGMs.
That's right. Yep.
So I think it's very important that as newer and newer next generation CGMs come out, those CGMs need to be tested to ensure that the interference is minimized. So again, these are all important practical factors that we need to take into account as we develop next generation artificial pancreas. And then again, talking about artificial pancreas, currently it's being developed in the US only for patients with type 1 diabetes. But eventually, we hope to expand that once this is, all the difficulties are smoothed out, and once it gets, the devices and the algorithms get more and more polished, why can't we use it in people with type 2 diabetes or in pregnant diabetes? And so, sky is the limit as far as refining these devices for not only type 1 diabetes, but other forms of diabetes also. And one of the major factors that this artificial pancreas does, and all these automated algorithms do, is that they reduce the patient burden so that the patient satisfaction improves. They can, spend more of their time enjoying life, rather than counting carbs, checking blood sugars, every few hours, bothering about how much to exercise, when can I exercise. So if we take out these burdens of the disease, then patients can enjoy themselves more. They can lead a fuller life. So that is the main issue about automating the system. But then again, these systems do not mimic nature, obviously. So in normal healthy people, when we eat, the sugar rises, the pancreas secretes insulin straight into the portal vein, which goes to the liver. Here we are giving insulin under the skin of the abdomen or arm or leg. It takes time for it to work, and that is also another limitation that we have to work with. Now, with the newer and newer insulins that are coming out, the faster insulins, the faster asparts, hopefully we will get closer to physiology. Now, talking about faster aspart and physiology, we recently did a study that was published in Diabetes, Obesity, and Metabolism, where we investigated how does faster aspart lower blood sugars.
Essentially, the goal is always to provide the insulin that will have the maximum or the best effect. And we want to lower postprandial glucoses. So, of course, one of the target organs is the liver, and the liver makes excess sugar in patients with diabetes. That is why they have hyperglycemia. And it's both in the fasting state and in the postprandial state. So what we did was we did a mixed meal study with isotopes. This is something that we've developed many years ago and published. And we took patients with type 1 diabetes and we tested out the regular insulin they were taking, their aspart, versus the newer aspart, which has a little modified molecule. So what we found was that liver glucose production seemed to suppress more with this newer fasting because it's acting faster in the liver. So because it's working faster, so it's suppressing the liver quicker. So less glucose is being made in the liver in the first, half an hour. And so it will improve postprandial glucoses. So this is something that has just been published, and we hope more and more patients can make use of this drug. But one of the things that he alluded to was, why do we really want to do this? And we shouldn't limit ourselves only in thinkings of type 1, but also, most importantly, the pregnant patients with diabetes, because our goal is to reduce glucose variability. So, patients with type 1 diabetes, they don't have insulin on board. The blood sugars fluctuate for everything. So if they exercise, they ate a meal, whatever they did, blood sugars keep going up and down, and that excess or the variability is what is harmful to the baby as well. So what we are trying to do is lower the variability down. So having pregnant diabetics monitor their blood sugars through continuous glucose monitoring, to be able to use an artificial pancreas is a huge deal, because it will cut down their stress, first of all, as mothers, expectant mothers, and it'll improve outcomes for the baby. So there's a lot of requirement for this, and as Andy pointed out, we have found, through discussions with patients with diabetes, et cetera, the disease burden is tremendous. If you think about a family which has diabetes, type 1 diabetes, the parents are involved, if the child has the disease, or other people get involved, and each patient spends up to 4 or 5 hours a day thinking about how much insulin to take, what should their blood sugars be, and that's a huge amount of work. They can't lead a normal life. So the goal of the artificial pancreas is we take the worry out of the families and the children or whoever has the disease and put it in the hands of the machine to do its work. But remember, it's too many gadgets, right? So we still have to come down to where we need one gadget. Otherwise, you think of a little child. The child is this little. How many machines can you put on that child, right? You have a monitor, you have an algorithm, smartphone, have an insulin pump. How many can this little kid wear? So that's where I think the technology needs to move.
And it's moving, in that direction. We are going to start a trial at the University of Virginia. It's a multi-center trial, multinational study, where the algorithm is in the pump. So the subject just wears a pump, and of course the glucose sensor is there. Eventually, we want to merge everything into just one device, one compact device that will be user-friendly and simple for the patients, so that, yes, we are taking the burden of the disease away, but we don't want to put a machine burden on them, because kids have limited surface area, so that's an important aspect, that we have to recognize. And one of the aspects also, as Rita mentioned, is the glucose variability, because the hemoglobin A1C measurement doesn't measure glucose variability. It doesn't say anything about glucose variability. So we are coming up with better and better measures of glucose variability, and we have to correlate that to changes in physiology to see whether, if we improve glucose variability, does the biology of the disease change? Does it improve insulin action? Does it normalize sugar metabolism in the liver, in the muscles, etc.? So far, these artificial pancreas studies, and even studies type 2 diabetes, and anything that uses CGM, their metrics are time within range, time below goals, time above goals, etc. What does that mean to the biology of the disease? Is it just the numbers that are improving, or is the physiology also that is improving? So we need to understand that also, that improving time in range, reducing glucose variability, does that translate to improved function of insulin, improved physiology, improved disease biology? So those things remain to be determined yet. We are in early days yet.
Essentially, as we are talking about the artificial pancreas, it is also very exciting for us that the Indian Institute of Science in Bangalore has recently been awarded a very large grant from the Indian government to do work in the artificial pancreas field. And they're combining the know-how of the technology, the mathematicians, etc., engineers, they're rocket scientists, along with the physicians, and we are consulting on that, and we are working together to come up with, maybe they will develop an insulin pump, an indigenous pump that they can manufacture, which will house all the information that we were talking about all this time. And so there will be one device, and this can be used, and it'll be cheap, so that patients in India can benefit from that.
Yes.
Because most of these sensors, et cetera, are very expensive, out of the hands of most people in this country. And so, you know, as we've of course moved, we trained here in this country, and we moved to USA many years ago and started building our research careers. But one of, at least our vision has always been not only to improve the health of patients in USA, but to give back something to our country. So we want to bring back our knowledge here, work with doctors here, Chelaram Diabetes Institute, Indian Institute of Science, Bangalore, et cetera, and give, you know, do some collaborative work and impart, you know, help them understand what we have done there and learn from them.
So the persons to contact for that in Indian Institute of Science is Dr. Padhi, Padhi, and Dr. Mala Dharmalingam from MSR, Bangalore. So she is the physician, and Dr. Padhi is literally a rocket scientist. He designs missiles and rockets for ISRO. So, you know, but he's a control engineer. So he's a mathematician and an engineer. So, you know, he approached us a few years ago. He wrote a grant to the ICMR, and that is the first project that was funded out of the ICMR now about 6 months ago. So they are doing a lot of good work. We looked at some of the data yesterday, and it's very promising work. So over the next 3 to 4 years, we should have a pilot, prototypical, indigenous, desi artificial pancreas. So because the pump is, they're going to build a pump which will be in their Kannada language, because it's in Bangalore, and it'll be cheaper, much more affordable. So, you know, we're looking forward to it. That'll be fantastic. That'll really be fantastic, you know, to bring the technology and the science back from US.
Back home.
Back home. That's the goal. Absolutely.
Thank you. Yeah.